Hi everybody, thanks for staying with us in ROC'n Recovery. I am with Dr. Minhaj, and I would like to know, what are you seeing in the emergency department at Strong?
Well, I see a lot of things in the ED, of course. I mean, we have everything from traumas to strokes, but I think one of the biggest things that we're seeing more and more of is the opioid epidemic. And it's not something new, it's been something that's been around for a number of years. It's only increased, and we expect it to continue to increase over the next few years. And we see this from patients that are acutely in withdrawal that come in, patients that have been so-called Narcaned in the field and come in and are there for safety, or those that have been mental health arrested. And we see all gambits of patients stable on therapy versus patients that really need to start on therapy that would really benefit from it too. All coming to the ED for some kind of help in this with their recovery.
Okay. Now, do most of the people coming in regarding a drug-related illness come in through like the police department, or do family members bring them in? What are you seeing?
Most of the time, I think it's primarily EMS personnel or police department that call EMS to bring patients in. I know the dynamic is changing because we know that it doesn't really benefit the patient, it doesn't really benefit society, it doesn't benefit the United States to arrest these patients for possession of these substances or dealing these substances unless they have in large quantities, because they're the ultimate end users. Those are the ones that we're seeing, the ones that are being harmed by what has happened with the opioid epidemic. And really what police and EMS, instead of arresting these people, they'll mental health arrest them, which means they'll call an emergency personnel to come and bring them to the hospital for us to take care of them, help them through their withdrawal period, or help them if they were Narcan to make sure that they're safe, that they're not at high risk for mortality, and making sure they're safe for the next few hours to take care of them, potentially get them started on therapy if they're willing, or making sure they're safe for those few hours that they may be at highest risk for death because of opioids.
Okay. I've heard from some families that when they go to the emergency department with their loved one, they get a hard time. Mm-hmm. You know, sometimes it's like they feel like they're not heard, they're trying to explain, they want information, they want to help the person. Did you see a lot of that there?
Sometimes we do, and it's difficult because these are often not straightforward cut and dry scenarios. There's often different social issues involved, different family members are saying different things, and it's hard to trust one person over another. And it's always good to remember that everyone in the ED versus the family member, everyone's really just trying to benefit the patient. No one is trying to do harm. That's your first instinct. Everyone is trying to help out the patient, do whatever is best for the patient. So I know sometimes it may be frustrating. I know Strong ED is one of our busiest EDs, and sometimes, unfortunately, some of these patients get neglected over higher acuity things, which, for better or for worse, is not always appropriate, but we try to do our best to take care of the patients that we can. And sometimes that may be have some time delays, and sometimes they may not. But it really, the big thing that we try to remember is we're trying to do the best that we can for these patients, to either link them to treatment, to help out the families. I know it can be frustrating sometimes because coming to the ED for this is not an easy thing to do. But we try to, like I said, we're trying to do whatever we can for the patient.
Okay. So when they come in, and addiction, obviously that's a medical issue, and the family approaches you, do you have somebody else to refer them to, or are you dealing with like all of the information from the family and from the patient, just as a person in the ED?
So we do have we have resources available that we can refer them to. We are not, as the emergency department is not like a detox clinic that someone can go to that we have around Rochester. Our social workers are great. We do love them because they have a ton of resources, much more than I would ever know. And they really are keen to helping these patients and trying to link them with different programs. And we've created different pharmacists that we work with, and social work has come together to create these lists of different resources available to patients. So those are being distributed to these patients as well to help out. This is where you can go to get some detox. This is programs that you can link to help in your recovery as well. All things that are going to help them out. Because we get different things from patients, different things from families, and what resources are available to help out these patients that are in recovery or have opioid use disorder or addiction.
Is the hospital using peer support at all to help these people? Like certified peer advocates for family members or for the people that have the addiction themselves?
Occasionally they do. I have seen on one or two instances. It's more difficult to happen in the emergency department. Not to say that it hasn't, but we have a toxicology service that helps cover a lot of the addiction medicine services as well. They're primarily on the inpatient, but they do cover some patients in the emergency department as well. And they do have some peer educators and patients who are in recovery who have gone through everything and come and educate new people in the ED and also in the hospital. We'd love to get it more expansive, obviously, because it doesn't happen too often, but when it does, it's really good because it really helps people to talk to someone who knows it. Because for me personally, I would not be a good peer educator. I personally have never thank God I've never had an opioid use disorder, but talking to someone that has and going through that, and because you can speak eye to eye, and that's going to be really beneficial to a lot of patients.
Right, yeah. And one thing that I love about you is I can see your heart when you're talking, you care. So that's awesome. So stay with us, everybody. We're going to be right back. Hi, everybody. Welcome back to ROC'n Recovery. Today we're talking about what happens in our emergency departments. And one of the things that you shared with us is that sometimes the doctors try to get them prescribed suboxone. Can you tell us like how that works? I mean, do they get a 30-day supply? How does it work?
Yeah, so usually you have to be in mild withdrawal to start therapy because suboxone, it's a weird drug. I mean, as a pharmacist, I know it's the weird pharmacologic properties of it, which I obviously appreciate a lot more than many other people do. But we want to make sure that someone is in mild withdrawal before starting it. So that's the one thing we want to make sure of. And a lot of education has gone to our nursing and our provider staff to make sure of that. And if they're willing to start it, we'll start with a dose right there in the emergency department. We'll give them a small test dose. If that works well and they are doing well with that, we'll give them a slightly larger dose. And then we'll give them different resources as well of treatment programs to see if we can link them to an appointment within the next few days. Because ideally you'd want to be linked the next morning if you could. But within 1 to 3 days, we'd really like them to link to an appointment, if not a week. So usually what we'll do is because there's restrictions on prescribing Suboxone outpatient, if the provider is able to, they'll write maybe a week's worth of a prescription just to bridge them to an appointment. Usually not more than that. If they are not allowed or are not certified to prescribe it, they'll usually just give a high dose while they're in the ED. That way it'll cover them for a few days because it has a very long half-life and lasts for a prolonged period of time. And that way they'll be somewhat covered as well until they can get their appointment in a couple days. I think one of the biggest things is by linking these patients to the program, that's really what gets them there, because we don't want to have 30 days out there because Suboxone, as many people know, is also abused on the street. And there's different perspectives that we see with that too. Some people prefer that say that, hey, I don't really mind, I don't really care. I would rather have somebody abusing Suboxone than abusing heroin, because we know when you're abusing Suboxone, the risk of depressing your respiratory rate and death is much lower than that is with heroin, with fentanyl, and whatever else is on the street. Additionally, you don't have the high-risk behaviors like needle stick injury and transmission of diseases with Suboxone. So there's some people on way in that column that say, I would rather flood the entire market with Suboxone rather than having people use heroin. And then there's people on this other side, completely very conservative, saying if somebody's getting Suboxone therapy, I want to make sure that they're getting treatment and they're getting better, and making sure that they're recovering and not just using that as another drug to sell and do different things and still have their opioid use disorder but not in a treatment recovery program. And you obviously have the majority of people in the middle of that chasm of like super liberal with it or super conservative. So that's usually generally where most people fall. Is I do agree that it's a much safer opioid than a lot of other opioids that we see out there, but patients do a lot better when they're in a program and not getting it off the streets, because we know opioid use disorder is has those behaviors associated with it, those high-risk behaviors that can perpetuate and then lead to different things that are more harmful. So we usually won't give a bridge prescription longer than a week, because that, again, increases the tendency of someone, it just increases the likelihood and that craving of, oh, I could sell this, because, you know, that suboxone's either your ticket to freedom and your ticket to recovery, or it could be that ticket to, I could also sell this and get something else. So we want to make sure that we're giving it to the appropriate patients, and we're getting it out there to them and linking them to a program to help their recovery, because that's really what we want. And I know we talked a little bit earlier about patients who don't even want this. Another thing that we often do is give these patients just naloxone or Narcan to discharge with, because at bare minimum, we want to give them something that can keep them safe. And we know Narcan can hopefully help keep these patients safe in the long term too.
Right, wow. So what if somebody wants to get into treatment, but they don't have anywhere to go? They're at the hospital. Do you ever come across cases where they're like homeless, or they just say that they have nowhere to go?
Yeah, and usually those are the most difficult ones to deal with. And I personally, we rely on all of our social workers to help out with those situations a lot. Because there are some inpatient treatment programs. Usually those are more difficult to find beds for. There's 24-hour detox clinics that can sometimes help these patients, but it's a tough situation, because you don't really have a place to send them home. It's hard to link them to different areas, and it's messy. I wish I had a good answer for you to say, oh, we had like a design program. We might. I just personally don't deal with it. We usually rely on our social workers to try and help in these situations to get the best possible outcome for the patient.
Okay. So as far as like which providers they're using and all that stuff, is that pretty much the social worker's job, would you say, or?
It's a little bit mixed. Social worker's job, also the patient's job, because we want to put a little bit of responsibility on, you know, everyone should share decision making and caregiving to both sides. And we have resources of different treatment programs that patients can call and get in touch with to help get an appointment and get started with therapy that we can usually give out to patients to discharge with. So that way they have a nice list of all the different programs that they can go to.
Oh, nice. Okay. Well, stay with us, everybody. We're going to be back. So, if somebody has a problem with addiction, do you ever recommend, or did you ever hear anybody else in the emergency room recommend abstinence? Just don't do it.
I think that's kind of a misnomer that originally maybe people thought that would just be easy to quit, but it's not like cigarettes or something that you can just stop and quit and it won't be there. That's a little easier to do. We know that opioid addiction and opioid use disorder is something that lasts lifelong in patients. It's not something that's easy to come off of. It's very hard to quit cold turkey, because what happens in the brain is it just gets rewired to crave this opioid, and that is something that can last decades even after abstinence and stopping abuse. So we know that that's really not a good option, and and the success rate with that is very, very low. All studies that have looked at that, the success rate with just pure abstinence without any medication-assisted therapy is very, very low to poor. We know that by using medication-assisted treatments, whether that be with naloxone, naltrexone, buprenorphine, methadone, all these different therapies, we know have a much higher success rate with patients. So that's why we will always recommend to use a type of medication-assisted therapy, because we know that abstinence only really doesn't work for a lot of patients.
I know of a case where somebody was being treated for another, like an infection that they got because they were using. And they said they were admitted into the hospital and they had heroin delivered to the hospital room. And, you know, like, you hear a lot of horrific stories like that. Do you see any of that?
Yeah, occasionally we do. Unfortunately, you know, a hospital is not like a prison. You can't regulate everything that comes in and out. There's so many different people that are coming and going, and we obviously try to do our best, but I have heard different stories of patients, and I've been on services where we had patients who had, you know, getting heroin delivered into the hospital for them. And it's a really tough situation, because one, how are they getting this? Because when we think about it, is how is somebody able to get this in the hospital? This is a place of treatment. This is where we want to help patients, and they're still able to get their opioids. So usually we try to confirm, because you don't want to make any assumptions. So we try to confirm that yes, this person is using while in the inpatient, and then we'll try and encourage them and see why are they still using. Can we get them on treatment? Because that's what's really going to help them in the long term. And like I said, we wish it didn't happen. But once we notice it, youth nurses are usually really good at picking up on that pretty quickly. And they'll let us know to go and check in on the patient, have a conversation with them to address the issues that they see.
I see.